As you're joining in, welcome. I'm Manish Schweigert. I'm one of the Asian Leadership Alliance leader, hosting this first series with our guest speaker here, Dr. Brian Lin. If you would like to add any questions, please use the chat and you can add questions directly to there. We will save some time for Dr. Lin to take your questions. I think I'm going to try to get us started here. Just want to make sure that we have enough time for folks to ask questions and to be able to interact with you during this session. All right, Nina, I'm going to head and get started. Cool. Good morning, everyone, and welcome. My name is Manish Schweigert. I'm one of the Asian Leadership Alliance leader. And today we are kicking off our new series, and it's called Sneak Peek. And the purpose of Sneak Peek is really providing a platform for our speakers as well as our EOG leaders to connect with our speakers to figure out if the content that they're sharing is important to them and they like to bring the speaker in to share that within their corporate environments or nonprofit organizations. So we're so glad that you're here. Thank you so much for joining us. Today, I have the privilege of hosting this conversation with Dr. Brian Lin. Dr. Brian Lin is a primary care physician, educator, and researcher. The cornerstone of Dr. Lin's work is keeping medicine focused on humans, patients, providers, families, and trainees, and not lost in the technology and algorithm. Very refreshing on that. His research and educational interests span across developing and testing novel medical technologies, improving health of Asian population with precisions and population health, and increasing expressions and interconnection in the health community with the humanity and arts. After receiving his undergraduate and master's degrees in electrical engineering and computer science from MIT, he completed his doctorate in internal medicine training at Tufts University School of Medicine and Tufts Medical Center. He came to Stanford to serve as a research fellow in cardiac electrophysiology and biodesign fellow, where he learned to identify unmet human-centered. Without further ado, I want to turn the mic over to Dr. Lin to share with us his research and his work at the Stanford Asian Health Research and Education Center. Dr. Lin, take it away.
Great. Thanks so much, Mani. Thanks for this kind introduction, as well as the invitation to speak today. Asian representation on health and Asian health disparities. Give me 1 second here. If you have any problems seeing the slides, let me know if there's any issue there. Today we're going to introduce myself and my background a little bit from the Asian perspective, talk about Asian health disparities and representation and disparity issues in Asian health, why we founded our Center for Asian Health Research and Education, CARE for short, overview of what we're doing at Stanford, and then we'll leave some time for the Q&A. A little personal story. This is not me. This is my dad, who immigrated to the US in 1962. He's sporting his best James Dean haircut. And I always heard this story that when my dad came here for graduate school, that he was invited among the very few Asian students that year to go to the White House. And I never really believed him because he couldn't provide. But I was able to look in the JFK archives and found not the invitation for him, but the invitation for the event from John F. Kennedy. So I was really amazed to see this. This is kind of an example. The reason I share my personal story is kind of why I decided to go and do research in Asian health, but also just to share my personal story about, which is so common among all of you, about how either yourselves or your grandparents or great-grandparents immigrated to this country. Just to show you here, I did find his name on the invitation list and his address at the time when he was in Maryland. And you can see here from China, which I think was mostly Taiwan at that time, maybe Hong Kong as well. There were 36 students invited, so very few students from Greater China invited at that time. Oh, it looks like actually there's a separate category for Hong Kong. So very few students from China at that time. You can see also very few students compared to how many students there are now from Asia in the United States. Wanted to share some information. I know you're all from ERG, Asian ERG groups from various companies. You can share a little data. We do monitor headcounts at Stanford by different race ethnicity groups. And you can see here that Asian groups are tremendously well represented. I think the postdoctoral scholars, a lot of is inaccurate because there's that huge chunk of 58% that are international non-resident. I think a large number of those are actually Asian as well. You can see among the faculty, there's almost a quarter of the faculty are by self-report of Asian descent, and among the staff, there are even more at 32%. So quite a diversity of representation at Stanford. So overall, 60% of the globe are Asians, 6% of the US are Asians, 30% of the Bay Area. So Stanford is really, and the Bay Area is uniquely suited to be an area of research and education for Asian health issues. I don't know if you could put in the chat here, I'll pause for a second. What percent of NIH funding in terms of monetary value goes to Asian health? So if you do a search, it may have changed this year, but this is based on 2019 pre-COVID data. What percent, take a guess in the chat if you'd like, of funding from the NIH goes to Asian health? Is it 10%? Is it 6%? Is it 1%? Is it less than 1%? So Mani said 10%, which would be kind of in proportion to, the Asian percent. So it's actually 0.17%, so less than 1%. Quite amazing that there's such low funding in the NIH for Asian health. So why did we start CARE, our Center for Asian Health? Well, there are a lot of diseases that disproportionately or differently affect Asians, including diabetes. A lot of Asians have what are called normal weight diabetes, which is different than also presents differently in Asians. Gout, there are different medication responses, pharmacogenomics, genomic and metabolic responses to gout medications. Gastric cancer, Korean, Japanese, and Chinese, people of Korean, Japanese, and Chinese descent have a several times higher risk for developing stomach cancer. High cholesterol, there are issues with pharmacogenomics of common medications called statins. They're actually metabolized less well in Asians. So actually Crestor even has a label that says if you're of East Asian descent, you should start at a lower dose. For South Asians, cardiovascular disease, much higher risk among South Asians than other Asian groups and non-Asian groups. Alcohol flush syndrome, hate to tell you, but if you flush and drink alcohol, there's probably an increased risk for esophageal cancer. So we don't recommend drinking if you do have the Asian flush syndrome. More common among Asians, especially East Asians. Nasopharyngeal cancer as well. There are many other items as well. These are just the few areas we're focusing on initially, and we're definitely expanding this list. In medical research, so we talked about, well, Asians in the world, Asians in the US, Asians at Stanford. Asians are really disproportionately ignored in medical research. So if you see here, in terms of the global clinical trials, Asians are around 11.8%, but of the global population, it's around 60%. So it's really more representative of the Asian population in the US, but not really representative of the Asian population in the world in terms of participation in clinical trials. So you can see here, this slide is really to speak to how it's important to disaggregate. In the US, we're treated all as Asian, no matter where your family's from in Asia. But you can see, just in this simple example, among Asian Indians, much higher risks and death rates of heart disease versus cancer, versus, for example, in Korean Americans, much higher risks of cancer versus heart disease. So it's really important for us to disaggregate the data so we understand and we have better insights on disease in Asian Americans. Again, example here, just about coronary arteries, the relative risks compared to non-Hispanic whites are very different across Asian subgroups. This is an example I love to give because I do this every day. I'm a primary care doctor, and people come in, their cholesterol's high, maybe they've got high blood pressure. And what we do is we calculate their risk of heart attack or stroke within the next 10 years. This is standard of care, guideline, evidence-based. And you can see what you put into the statistical model, which gives you a risk prediction. So you look at people, the race, ethnicity, blood pressure, cholesterol, medical history. And you can see here, there are really large buckets in terms of race, ethnicity, white, African-American, and others. So I believe in terms of the audience today, most of us fit in the other bucket. So, and the reason is this is really based upon data in the US. And you can see here, there's a footnote here. You see this asterisk, and see when you click on this, if you go to Google American College of Cardiology, ASCVD, you can find this webpage, and you can see the asterisk, and it says see estimate warning below. It says these estimates may underestimate 10-year and lifetime risk for persons from some race ethnic groups, especially American Indians, some Asian Americans, especially, for example, of South Asian ancestry, and some Hispanics, and may overestimate the risk for others, including some Asian Americans, for example, ancestry, and some Hispanics. So really, this risk calculator is not necessarily that accurate for you if you're Asian. And why is this the case? Most of these risk estimators, this statistical model is predominantly based on a lot of data from something called the Framingham Heart Study. And this has followed people over 3 generations in around Framingham, Massachusetts. And you can see here, EA is European Americans. So among the original, the offspring, the 3rd generation, and offspring spouses cohorts, Framingham had 100%. It consists of 100% people of European American descent. So there were 0 Asian Americans, 0% Hispanic Americans, 0% African Americans. So they did try to change this in more recent years with the Omni 1 and Omni 2 cohorts. But you can see that's still a fairly small percentage compared to the whole study of Asian data involved, with a very crucial issue, which is determining whether you need to start a medication called statin class medication, which is Lipitor, Crestor, and those types of medications. So it's unfortunate we have a lack of data in this area. And we need to change this, and that's part of what our center is working on. I'm going to share with you a case study. This is a patient of mine to share his story with you, and part of what inspired me to reach out to my colleague, Dr. Latha Palaniappan, to start the Center for Asian Health about 5 years ago. As a 74-year-old man with recurrent gout, and decided to take a medicine to prevent his gout flares. I prescribed a common medication called allopurinol, and unbeknownst to me, not commonly recognized in the US, East Asians in particular Han Chinese descent can develop a life-threatening skin reaction called DRESS. And he was hard, high-dose steroids to treat him. There's no indication on the FDA label that we should take care in certain subgroups. So again, an example of where pharmacogenomic differences, which could be tested with this HLA-B5801 testing, can be important in the care of our Asian patients. And so you can see here, it's an issue that doesn't only impact Asian, but also African Americans. So this genetic marker is also quite elevated in African Americans, which correlates, as you can see in the right graph, with a higher risk of this allopurinol-associated adverse reaction. So again, yet another example of why we need better data and better education about Asian health. We started care not just in isolation. We have to recognize that we had lots of our colleagues who've been working on these issues. Dr. Samso in particular founded the Asian Liver Center over 25 years ago to focus on ending hepatitis B and liver cancer, which again is also highly prevalent among Asian groups, in particular East Asian groups. And he's been also very effective. His center has been very effective on promoting policy changes such as AB 789, which required primary healthcare facilities to offer voluntary Hep B and C screening tests for all Californians. So this is an example of how a rising tide lifts all boats, because we can have this offered for all Asians, but also all Californians who also may be at risk. So we founded CARE about 5 years ago, and we've had amazing support from the community. Our vision is to become the premier academic leader in precision Asian health. And our mission is to improve the health of Asians and Asian Americans by increasing knowledge and empowering education to positively impact their clinical. So our team here, again, the reason we list our faculty here is I know several of many of you lead ERG groups in your own companies. So we're happy to try to match you with speakers that may be of interest to your companies. And not only the main leadership team, but we also have a lot of people who are focused on specific countries, which would be of interest to your groups as well. Areas and medical areas as well. And I'm happy to share this slide deck as well. And we have a great staff, the leading operations led by Sally Lee, and we have lots of folks helping our program. The 3 pillars of CARE are research, education, and community. We have our own initiated research, but we also support research within and outside of Stanford. We have several educational programs, including for college students looking at Asian data and big data with Asian health issues. And that's been ongoing for several years, run by my colleague, Dr. Malathi Srinivasan. We're also thinking about starting a high school program as well. And lots of community programs, including community health talks in English, as well as in-language talks that are going to start in May. Just wanted to talk a little bit about the impact of our center. You can see since year growth of publications, and publications are one of the metrics that we use in academic medicine at universities to determine our impact. And you can see the blue area is the impact that we've had in terms of the growth of publications related to Stanford research on Asian health. Overall, we've had a tremendous impact. We've had a large number of journal articles, grants awarded, new funding. We also one of my colleagues relaunched the Journal of Asian Health, which has really become a pillar of academic output in terms of a location venue for publishing work in Asian health. I mentioned the CARE Scholar Summer Program as well, and we're also very active in our national conference presentations and holding various summits and Asian health courses. And I talked about some of our community work as well. Wanted to talk a little bit about the Pew Study. Asian hate is very close to all of our minds still, although it may have lost some of its prominence in popular media coverage. In 2020, right after COVID started, we saw that Pew had done a survey on Asians, Hispanics, and Blacks and whites, and we saw that they did not disaggregate Asians, and they really did not sample many Asians. They only sampled 278 Asian Americans without disaggregating them. In terms of the fear of physical assault or threat, there was about a 2.9 times risk of Asians being worried about that than whites. We did our own survey, and you can see here disaggregation was really important, and it really the Pew study really because of the aggregation, there was even a greater concern among certain Asian subgroups. You can see really among Chinese, Korean, Japanese, Vietnamese, than the 2.9 times fear of risk of assault. It was a 5.4 times in the case of Vietnamese Americans. So, and you can see among other Asian subgroups, there was less of an impact. So this disaggregation really provides a lot of insight about how anti-Asian hate has been and continues to be a big issue in our community. Another initiative we're focused on to improve coverage. So for example, if you're above the age of 45, pretty much can get a screening colon colonoscopy or screening stool test for free at no cost because it's considered a preventative test. But stomach cancer screening is not covered for you. Myself as a physician, we have to find out whether you have any symptoms and then order the test based on your symptoms like reflux or stomach gastritis, stomach pain, dyspepsia. So my colleague, Dr. issue to get a policy change so that upper endoscopy, having a camera to look, through a fiber optic scope to look at your stomach, will be covered by insurance as a screening test, which is commonly done in Asia. Next thing we are working on is, as I mentioned briefly, alcohol flushing syndrome. My colleague, Dr. Chih-Hong Chen, is working on this. There's a high burden of alcohol flushing due to an ALDH2 gene mutation. It affects almost over a half billion East Asians. And we're looking at, of course, generally alcohol consumption is a big problem in most communities. And Dr. Chen has been leading a No Alcohol Day campaign in Taiwan, and we're hoping to broaden the outreach of this public health initiative. Wanted to highlight a few projects that Nina Lee, who is our capable community program director. We have several AAPI Heritage Months. Happy to collaborate with you on that. We are also ethnic media services on health briefings and as well as determining the impact of their programs. And we're going to start doing programs with the Chinese hospital, starting with a health fair in early May. Wanted to also invite you to spread the word about our Health Equity Media Fellowship. I think the due date technically is in April, early April, but we're probably going to extend the deadline. We're looking for 2 fellows, one from a healthcare background and one from a background, to spend a year at Stanford with a stipend to learn about how do you tell stories to spotlight problems and health equity issues in the Asian community. So we'd love your support. We've got local and global impact. We've got, of course, a fantastic worldwide reputation being at Stanford. And really our location is unique in terms of getting all the major Asian subgroups here in the Bay Area. We're very active and very open to working with all of you in our community. Wanted to also just mention, and I don't know if Nina's going to have a chance to talk about this. Maybe we can talk about it in the Q&A. We have a corporate lunch and learn program, so please contact Nina Lee if you're interested in that. We're happy to provide speakers for any of your corporate events to spread the word about Asian health. So you can see now here, she's our program lead for community programs. Great. I'm going to stop my presentation and open it up for Q&A.
Thank you so much, Dr. Lin. I would open this time for our attendees, audience, to ask any questions you might have. If you are comfortable, you're certainly welcome to open your camera and mic to ask the question directly. And if not, go ahead and put your question in the chat, and then we can funnel that to Dr. Lee. Dr. Lin.
I think one question I frequently get are, how does this impact my own health? So I think one way is to, talk to your doctor about it, but also come prepared for your doctor's visits. Bring information, bring questions about, should I be screened for hepatitis B and C? Should I be screened for diabetes? Even though people, so for example, the risk for diabetes in Asians goes up at a BMI, body mass index, of 23, whereas really 25 in the US is overweight. So this is something you need to be aware of about your own personal health needs. So make sure that's important for you. And then in terms of depression and mental health issues, Asians tend to underreport depression or describe it differently. So if you're impacted by mental health issues, please seek support. A lot of companies, programs, but also contact your own doctor as well regarding communicating about mental health issues. Okay, great. Yeah, fantastic question. Is there routine testing in Asians for H. pylori? Yes, some countries have instituted this. Some countries preferentially do endoscopies, which can be more expensive. It's sort of a little bit of an analogy between testing for colon cancer screening versus a colonoscopy. You can, of course, have H. pylori negative and still be at risk for stomach cancer. So this is where I think there is a somewhat of a preference for upper endoscopies. But yes, H. pylori is one of the major risk factors. So I think it's a very good point that it may be more cost effective. We don't know that yet. There's definitely active research going underway about whether doing stool testing or antibody screening for H. pylori, would that be a more cost of identifying people who are at risk. So it's a great question. Oh yeah, excellent question about socioeconomic factors in aging health. Absolutely. So a lot of people are not aware. In America, Asians have the top quartile of income of Asians have the higher income than whites, but the bottom quartile of Asians in terms of income are also the poorest in the US. So we have the biggest in terms of racial income disparity. So there are tremendous issues of just related to socioeconomic factors, what we call social determinants of health. If you don't speak English, if you're an immigrant, all of those impact health, and those are all things that we're working on. But we, from an academic perspective, want to start with getting more data about that. Yeah, so excellent question. What partnership do you have with pharma? So I was part of a group, and we got a grant from the American Heart Association looking at increasing diversity in clinical trials. What we're doing is we're looking at different interventions, such as something simple as, hey, we're going to give you an Uber ride certificate, ride coupon, so you can come to the hospital. We're reaching out to you on Facebook or Google Ads, and we're looking at what is the most effective way of reaching out. And pharma is actually very aware. They are under pressure by the FDA to increase the diversity of their clinical trials. So there's a lot of openness to spending part of their significant budget on increasing diversity. So there's definitely a lot. Yeah. Oh, the great question. So the lower dose would be the lowest dose. So a lot of in terms of Crestor, they recommend starting at 5 milligrams instead of a 10 milligram or 20 milligram dose. A lot of our recommendations, as you saw from the risk calculator, would be to actually start at a medium. So my general recommendation, because they only have a specific recommendation for Crestor, but my personal recommendation is for Asians to start at the lower dose and then increase it to reach the goal. Typically, the goal for that would be a 50% reduction in LDL, the bad cholesterol. Okay, great. So very interested in the slides. We will welcome we'll share the slides. We don't, because this is sort of more of an overview talk. Happy to in-depth talks in specific areas if you're interested in. We talked about cardiovascular disease and cancer in particular in terms of the differences when you don't disaggregate Asians there. Yeah, how can you bring more awareness? That's a great question. I think just being open to it. A lot of universities like Stanford will let you kind of self-label as, hey, I'm interested in research. You can contact me regarding this. So there, and I don't want to be too Stanford-centric. Our colleagues at UCSF have also a kind of a registry called CARE that is basically allowing people to register for specific Asian research, Asian health research. I think they're more focused on lung cancer screening, but I believe they have that kind of a little checkbox to say, hey, I'll be willing to be contacted for research. So it's a great question. I'm wondering if you have any regarding Asian patients and care-seeking behavior. Is there more reluctance of Asian patients to seek care? And does that impact the treatments that are available to Asian patients? Absolutely. So I myself was involved with a study that Dr. Grace Yu out of San Francisco State worked on in collaboration with CARE. And we specifically were looking at Asian elders who don't speak English during COVID. And there was tremendous impacts, barriers to care in terms of transportation, language, access, fear. So yeah, it does impact care-seeking behavior, and COVID has had a huge impact. Overall, yeah, there's not a lot of data in terms of broader Asian community seeking reluctance to care, having reluctance to seek care. There's more data on like non-English speaking populations, immigrant population. Definitely that's the case in those populations. I think there's less data on, for example, American-born Asians.
Maybe you want to contact Dr. Lin to become a speaker within your corporation or communities, you can certainly reach out to him directly. Of course, Asian Leadership Alliance are here to help you with any resource that you might need, or if you need to get in touch with Dr. Lin, feel free to ping us. As a matter of fact, if you haven't already joined Asian Leadership Alliance, go right ahead and ping me. I can send you the link as well to join. We are on LinkedIn, Facebook, Twitter, Instagram, you name it, we're there. The purpose of our community is really to bring all of our Asian leaders together to be a resource to one another so that we can uplift each other. As a matter of fact, as we're preparing for our ANHPI Heritage Month in May, is that we are putting together a toolkit if you need to or want to learn how to celebrate the Asian Heritage Month in May. It's available to you. Feel free to ping me and I can share that information with you. And if you want to bring Dr. Lin in to be a presenter within your corporation, we can work with you on that. And Nina has his schedule, so she can help connect you as well. All right, it looks like we have 2 more questions coming in, Dr. Lin.
Yes, any opposition from beverage companies to your flushing research? My understanding is there's not been overt opposition, but I can imagine that there will be opposition in the future as this gains steam, because it's relatively had a fairly small footprint so far. My understanding is in Taiwan there was some kind of a little bit of pushback. I'm not quite sure exactly what form that took, but I can imagine as this gets more broadly recognized, that there will be increased opposition, as there has been from many areas. I mean, from the history of smoking, right? We saw that as well. Continuous glucometers. So, in particular in the Bay Area, we have a very tech-savvy population and a population of early adopters. So I have a lot of people ask me for CGMs. So a couple of things. So basically, they allow you, it's a wearable patch typically. So there are 2 big companies that do this, is Libre and Dexcom. And you wear this patch, and you can usually just use near field and then interrogate it and get your sugar at that time. Not as accurate as finger sticks, and of course not as accurate as the blood, but it gives you a good estimate of kind of your relative change. I think it's great. I think it's not covered well by insurance if you don't have diabetes. If you do, so for example, with Medicare, if you're on insulin, they will cover it. If you're not on insulin, you usually don't cover it. Some private insurances will cover it, even for most of the time. I've not seen it covered if you're not a pre-diabetic or diabetic at all. If you're not a diabetic or pre-diabetic, probably if you wanted to use it, as in my experience with my patients, people will buy, maybe 1 or 2 sensors. I think you get a coupon online and wear it for, usually a sensor lasts for 10 days to 2 weeks. So you can wear it and get data and then use that to change your behavior. I think it's very effective. I don't think it's for everyone. But I think if you're open to it and interested, it can impact. I kind of joke around with my patients and some of my colleagues that, well, a lot of insights people have are things that they probably already knew, but it really was driven home because it's personal to them. So I'm always a big fan of anything that will change behavior for the better. So I think it's great to do that but there's payment and insurance. And then another question, also you can do endoscopy at the same time you get a colonoscopy. Yeah, so not always. In my experience, they usually consider them separately in terms of payment. Maybe some insurance will do that, but most of the time, at least in my experience as a primary doctor, I have to come up with a symptom or find a symptom from the patient for that. So yeah, it's unfortunate. Generally covered for screening. So if I put down, oh, somebody's of East Asian descent, they need to be screened for stomach cancer, but they have no symptoms, usually that will get rejected by insurance.
All right. Dr. Lin, I think we have one question in the chat, and I Thank you. I mentioned a little bit of this already in your presentation, but maybe just repeat it again. In terms of diabetes, what are Asian American risks compared to other ethnic groups?
Yeah, so it's a great, of course, there's, everybody brings up diet because Asian diets are very carb heavy. So it's very interesting though, if you take somebody of the same kind of weight and, and the average Asian of the same weight, same diet compared to them to a non-Hispanic white, they still have a higher risk of diabetes at that weight. So, if you say, hey, everything it's the same, because the Western diet is still very carb heavy. But of course, what I view it as in terms of there's absolute risk, right? So what can you adjust? You can adjust your weight. So BMI is body mass index. So that's your height normalized by your weight in metrics. So you take your weight your weight in kilograms and divide it by your height in meters squared. There's lots of online calculators, so you don't have to do the unit conversion. And again, the BMI, the American Diabetes Association has actually an initiative that says, if you should screen at BMI of 23 for people of Asian descent, both South Asian and East Asian. So there are probably genetic factors involved, but of course, environment, you can't extract out environment and genetic factors. We actually have a study ongoing now looking at DNA methylation, which is DNA expression of diabetics above the age of 65 to see if that's a predictor of or death. So, it's very interesting that it's not just about the genes you have, but also whether they're expressed or when they're expressed. So there are a lot of complex issues there. But in terms of modifiable risk factors, weight, of course, exercise, muscle mass tends to be different in Asians than non-Hispanic whites. So, doing weight-bearing exercise, increasing muscle mass, diet, of course, and change your genes. So not yet. So those are the things you can work on.
All right, a couple more questions for you here. How about Asian American mental health? Asian minority myths and stigma prevent Asian Americans from seeking mental health support and services.
Yeah, absolutely. So there's a lot of stigma. So I think people tend to underreport. It's under-recognized. That's part of minority myth comes into play. So we have to educate not just patients, but also providers. We need to make sure that the providers are aware to screen for mental health issues. Language is tremendous. It's very interesting. We had a class where we had students who spoke different Asian languages, and we asked them, hey, what's the word for depression in the language where your family comes from? And it was very difficult for these students because they said, well, there are like there could be 5 different words. Nuance you're asking about, or geez, I'm not sure there is a word for depression in my language. So, how you express that idea of depression, mental health is also challenging. So I think you have to, one, increase education of providers first, I think, just to screen and to recognize this may be an issue in Asian patients, but also non-English speaking Asian patients, but also educating patients to ask for help, to seek resources. It can be very challenging. There's also stress and pressure, and there's of course been a lot of attention in the Bay Area, in particular Palo Alto, on mental health of teenagers and school and school pressure, and that's also something that people are working on, and it's a challenging issue. One of my colleagues, Dr. Rona, who is in psychiatry, she runs called a SMART clinic, which is an Asian mental health clinic. So I encourage you to check out her clinic. I think it's SMARTH or something like that. But if you just Google Rona Hu, an Asian clinic, that may you can read more about her work and her clinical care. And from Scott Lamb, he's asking, you've mentioned that the ACVD risk factor might not be accurate for Asians. Is there another? No, we don't have that. This is the big problem. We don't have that. As you can see, Framingham is built on a lot of data, right? There's over thousands of people there. We don't have that Asian Americans, and this is again very specific. Even if we had that data from Asia, is it applicable to Asian Americans? We really need to gather that for Asian Americans and disaggregate. So that becomes a challenge because Asians are spread all through the country. They concentrate in urban areas. So we need to get better data. So that's part of what we're working is creating big data sets of Asian Americans and looking at their long-term risks.
Wonderful, Dr. Lin. Thank you so much for that. We have one more question coming in. It said, in terms of alcohol flushing, what would be an appropriate amount for alcohol if I do have alcohol flushing?
Yeah, so people are going to yell at me for this. I mean, to me, there's sort of no amount of alcohol if you do have flush. I mean, rare, of course, intermittent. I would not drink regular alcohol, right? Alcohol on a regular basis. And then if this is like a special occasion, I think probably it's not going to make it big. Likewise, you can draw the analogy to smoking, right? Is any amount of smoking good? No, no amount of smoking is good. Probably the same for alcohol. And we have increasing data even for the non-flushing population that even small amounts of alcohol probably not good for you. So I personally would recommend staying away. After I learned this, actually, I pretty much cut out alcohol. I flush. My parents are from Taiwan, I minimally. I don't think I've had any alcohol in over 2 years, probably about that. So I've really cut it out. But as a primary care doc, I know there's a balance, and you've got to, certain things you enjoy, so you've got to figure that balance for yourself. But in terms of, the science and the evidence, I would say probably no amount of alcohol is good for you.
All right, one more question. Since there is limited knowledge and data available to help us understand how certain medicine impact us as Asian Americans, does that mean we have a higher risk of having side effects?
Probably there's an unknown risk. I wouldn't say it's higher. It's an unknown risk because we don't have the data, right? Maybe we have a lower risk, right? It may be, hey, you have a lower risk for some other side effect that other people get, right? So I would say that's unknown. We just don't have the data. My colleague runs the pharmacogenomics clinic. So where you can get pharmacogenomics testing. So they look at your different known genetic markers for metabolizing drugs. Is that 100% comprehensive or complete? Probably not. But we do have some data there in terms of certain genetic markers. So that testing is not typically covered by insurance. I think it costs something like almost $1,000. But if that's something you're concerned about, that's something you can seek out testing. Again, I think we're in early days of data and gathering better data on that. Hopefully that day will come.
Mm-hmm. All right, really good questions, audience. Anything else you want to ask Dr. Lin? I'm trying to look at both the Q&A as well as chat. Keep them coming. Again, you are invited to unmute yourself if you want to ask a question on your own or directly to Dr. Lin.
And for any of you who are interested in helping out, welcome volunteers. With our Asian health fairs. Of course, we are. Everybody thinks Stanford is very well funded and rich, but all that money is typically accounted for and goes to programs, existing programs. So if you would like to contribute to CARE, either in terms of your time, treasure, or talent, we'd appreciate that. I know there are a lot of corporate matching programs as well. So Nina can put the link into how to make a contribution, and you can reach out to Nina if you'd like to volunteer for one of our events. Typically, we do events in terms of community events in collaboration with a community partner. So if you are part of a group that would like to collaborate, like for example, with the Chinese hospital, we're doing an Asian health fair, a health fair with them. We're happy to collaborate. We typically don't like to do programs by ourselves because we want to really join together. So please let us know if you are a member of a group that would like outside of the ERGs and corporate, or you personally want to help out. Happy to speak with you and get your help.
Mm-hmm. Those are great ideas and ways in which you can help to bring more awareness. The other question is, would it be helpful to talk to policymakers as well too, in terms of healthcare underrepresentation from the Asian community?
Absolutely. Yeah, this is always a challenging area. I'd say, for ourselves, it helps to be focused. So I think specifically about stomach cancer screening, that's a very focused area. So the more they hear about it, the more likely, this is going to be, there's going to be some policy or legal change to have this covered so that, it's at no cost for the patient. As well as, in terms of alcohol, right? In terms of, that awareness or putting into guidelines about the dangers of alcohol. And as, a lot of corporate and industrial interests in terms of alcohol. So it may be an uphill battle there. So yeah, all of those are great. Yeah, if you can talk to your congressperson about how this is important, we need more data. We need more money, more funding, NIH funding toward Asian health. Absolutely, all of those would help.
All right, and there's another question coming in the Q&A here. Is there any research on how health risks differ from mixed race Asians? Really good question.
Great question, yeah, and that's part of why we founded CARE. So, in my kind of cohort of people, there are a ton of our children are of mixed race, Asian, non-Asian. And yeah, honestly, we don't have a lot of data. There was a study that's quite old about multiple generations of Japanese going to Hawaii and California. That's about it. We don't have a lot of that. Not only do you have to look at, the children who are mixed race, but you want to look at their adult parents, right? That's how you really get that great information about risk, right? Because if so that, yeah, we don't have that yet, and we hope to build those types of data sets. It's a great question.
All right. Any more questions we have from the audience? I know we're closing up to the hour here. Want to give you some more time with Dr. Lin. If not, if you think of other questions later on, feel free to send it in to us. We'll make sure that Dr. Lin get those questions and answer to you. All right. It sounds like you answered everyone's question, Dr. Lin. I appreciate it. Thank you so much, everyone, for attending and being part of this conversation today. We hope and encourage that you would take this information and bring it back to your community. And if you'd like to hear more information, details from Dr. Lin, Nina has shared some information in here in the chat. Go ahead and copy that and share that out. Thank you so much, everyone.
Great. Thanks so much.